Hello everyone, this is going to be chapter 51. I split it into two slide presentations, so it'll be two short lectures. It's not a very big chapter, there's a lot of things that have been covered before, so we're just touching on some key points in here. And believe it or not, this is the beginning of your very last unit for this class. Anyway, so let's move on. So this part of the lecture is the first part of the chapter, which goes over bone healing fractures, complications from fractures, how to manage them, and some specifics to certain sites. Musculoskeletal trauma, of course, the plan is to first assess for life-threatening injuries. Remember your ABCs, and then your bleeding, and remember everything we did in the beginning of this class on traumas and injuries, and doing your initial screen and your second screening. So types of fractures. Your text goes over the types of fractures on page 1052. I just thought this picture was kind of cute in remembering the different types of fractures, and explains each one underneath it. Diagonal, occult, which is break is hidden or not easily recognized. Open, of course, is if it protrudes through an open wound or through the skin. Pathological is a result of a disease rather than an injury. Segmented, the bone is splintered into pieces. Spiral is when it is a twisted fracture. Horizontal is transverse or straight across, like when you look at the horizon. A green stick is a partially bent or partially broken, which really you'd see more in pediatrics. And then impacted is a bone that's wedged into the interior of another bone. Some specifics here, I just found some pictures to help bring it home for you. It discusses it on page 1052. On the pathological fracture, which occurs when abnormal force is applied, or the bones are already weakened, such as an osteoporosis, cancer, sarcoma, benign bone cysts. Over here is a key picture on compound fractures. Occurs when a bone snaps like a twig and pokes right through the skin. That is a compound open fracture. Here's two pictures talking about your stress fracture. Your stress fracture is also a fatigue fracture that results from excessive strain or stress on the bone, commonly seen in professional athletes. And then here's a picture of a vertebral compression fracture. Compression fractures don't have to always be in the vertebra or in the spine, but that is the most common place that you will see it. It's produced by a loading force applied to a long axis of cancellous bone, commonly in vertebrae of older adults with osteoporosis, and is extremely painful. This goes into your bone healing. This has been covered before in PEDS and in some other classes. Your text goes into the stages of bone healing. Again, this is a different picture than what is in your textbook. Depends on where you look. Your text refers to 5 stages. This was just good in giving you the time frame it takes for each stage. In the first 24 to 72 hours after an injury, that's when you have the hematoma that's forming right here at the site of the fracture. It's because the bone is very, very vascular. Stage 2 is between 3 days to 2 weeks, so that's somewhere in these two would be into stage 2. When granulation tissue begins to invade the hematoma, this then prompts the formation of fibrocartilage, providing the foundation for bone healing. That's where it has these two going to one, where it says right here, the soft callus, unmineralized cartilage. So it's a very weak link. Stage 3 of bone healing occurs as a result of vascular and cellular proliferation. The fracture site is surrounded by new vascular tissue known as callus, and this is in the week, within 3 to 6 weeks, this formation takes place. Here, in this picture, it talks about the fibrous tissue and then your secondary bone where your callus is forming. And then as healing continues into stage 4, the callus is gradually reabsorbed and transformed into bone, and the stage usually is 3 to 8 weeks. And during the 5th and final stage of healing, consolidation, remodeling the bone continues to meet mechanical demands. The process may start as early as 4 to 6 weeks after a fracture, can continue up to a year depending on the severity of the injury, the age, the health, the mobility, multiple factors, risk factors. Younger will heal faster than older. The younger usually heals within 4 to 6 weeks, where an older person can take 3 months or longer, especially after age 70. Other things such as what type of trauma it is, if there's an infection, what kind of vascular flow, do they smoke, are they mobile, do they have cancer or some other disease. I just thought this was a cute picture to put in here. Are you sure the doctor said it takes 14 weeks for your leg to heal? Obviously, no. Somebody's milking it. Okay. Some things to keep in mind when you're going over your notes and thinking. What should the nurse be most concerned about regarding a patient with a fracture? How does this fracture affect mobility? What complications could this fracture cause? How does this type of fracture affect the healing process? What medical surgical treatment should the nurse expect to occur? These are what I want you to keep in mind. Neurovascular assessment. Well, a couple of slides, it talks about the 6 Ps. Some places say 5 Ps, but really focus on the 6 Ps on your neurovascular, but your whole muscular assessment, your color, temperature, pain, movement, sensation, pulses, capillary refill. Complications of fractures. There's multiple complications. Your text has it kind of, does have a list here. The acute compartment syndrome, different kinds of shock, fat embolism syndrome, venous thromboembolism that can go to multiple places, infection, ischemic necrosis, fracture, blisters, delayed union, non-union, malunion. I think your text is a little different. It's the same things, they just listed a little different format. Okay, so you should remember from last semester compartment syndrome, and we brought it up again in the trauma at the beginning of this semester. Here's your 6 Ps: paresthesia, pallor, pulselessness, poikilothermia, paralysis, and pain. The pain is out of proportion to exam. Usually the pain suddenly gets much worse. Poikilothermia is the temperature of the skin, usually getting very cold because there's a compartment that is closed off. You lose your pulse, it's pallor and numb. This is a really good picture showing that we have all these different compartments. Usually it's a long bone fracture, the tibia being most common. One of those compartments gets swollen due to the injury, increases pressure in the blood vessels and nerves, leading to compromised blood flow. The pressure, rather than being 0 to 10 millimeters of mercury, it can be greater than 30 to 40. That leads to ischemic necrosis. That is a medical emergency, and they need to do an immediate fasciotomy to relieve that pressure, or you will lose the limb. I know we talked about this before, so I'm not going to dwell on it. You do have on page 1054, chart 51.1, that goes over the physiological changes that are taking place. The increased compartment pressure, increased capillary permeability, that's what leads to the edema, the release of histamine, which increases your edema, increased blood flow to the area. The pressure on the nerve endings, causing pain, increasing tissue pressure, start to increase the production of lactic acid and anaerobic metabolism, so it gets cyanotic, vasodilation in that area, worsen the edema, muscle swells, become tingling, numb, lose sensation, and the pain becomes severe, is not relieved with any pain medicine, and the tissue begins to die. Your text mentions the crush syndrome right after acute compartment syndrome, but it does not go into it. I'm just going to let you know a little bit of what it is. Not usually directly due to ischemia. Main cause is a stretch of the muscle and influx. It's a crush injury. Muscle swelling can then cause early or even days delayed compartment syndrome. This is a really good picture here. It goes over the difference between a crush injury and compartment syndrome. It has your 6 P's again in here. It talks about the difference between the two, the compartment and the crush. So just not that you need to know a lot about the crush injury here, but just be familiar with some of the differences of the two. I didn't put a slide in here on the hypovolemic shock because we have covered that before, but because a bone is very vascular and it can have a great risk for bleeding, which can lead to hypovolemic shock. So now we're going to talk about fat embolism. Your text talks about a fat embolism syndrome. Happening 12 to 48 hours after injury, your fat emboli are released by the bone marrow. In 90% of severe skeletal injuries, it's more common if there's multiple fractures to go into fat embolism syndrome. But fat embolism itself, very common, 90% of skeletal injuries. It leads to pulmonary insufficiency, neurological symptoms, anemia, thrombocytopenia. These are the symptoms: tachycardia, dyspnea, neurological syndromes, inability, irritability, restlessness, delirium, coma. Pathogenesis is the mechanical obstruction and biochemical injury. If you can see on your pictures over here, that the fat emboli, I said, are common. The syndrome itself is actually a physiological response to the fat that are within the systemic circulation. Fat embolism does not always result in fat embolism syndrome. Fat embolism syndrome occurs in probably 1% of them. The fatty particles are released from the bone marrow, from the yellow bone marrow, and they get into the bloodstream. They start to travel in the bloodstream, but they are very big and they block things. They can get to the lungs and they block the alveoli. If they make it, parts can make it through and get into the brain, causing the neurological symptoms. And like in the lungs, the fats degrade into smaller particles and release this fatty acid that literally burns the tissue, causes vascular problems and leaking and damage, and leads to this fat emboli syndrome. As your text says, it can occur at any age. It is more common in men between the ages of 20 and 40 and older adults between 70 and 80. Hip fractures have the highest risk. And here we go, also fat embolism syndrome, fractures of the pelvis within 24 to 72 hours. Earliest manifestations of the fat emboli syndrome are low arterial oxygen level, hypoxemia, dyspnea and tachypnea, which of course is the damage that is occurring in the lungs. It can spread to neurologically. They have headache, lethargy, agitation, confusion, decreased level of consciousness, seizures, visual changes. Remember fat emboli versus blood clot emboli is the fat emboli have petechiae in the chest and axillary area, which you don't have in a thromboembolism, a blood clot embolism. You have some abnormal findings in your labs. Your PaO2 is low, below 60. As I mentioned, that you're going to have the problem in the lungs. Your SED rate, or ESR, is going to be elevated. Your serum calcium is low. Decreased red blood cell and platelet count, because you start to go into a shock scenario, and you're getting abnormal clotting factors. Your lipid level, of course, is going up because your serum lipid level because of your fats. And we'll talk a little bit about pulmonary emboli, because we've covered that plenty in the past. You have venous thromboembolism, or VTE, in the deep vein. That's a complication just from the fracture itself. It puts them at risk. I just found this chart that I thought helped show just the fact that you have the fracture. Hips, major trauma, spinal cord injury, any of them put them at risk. And if you add in these other factors along with these predisposing, and then you have the injury, and you have greatly increased the risk of throwing a thromboembolism because of the clot formation. Your text has a chart 51-2 on page 1055 comparing the fat embolism with the blood clot embolism. I also found this chart, whichever one helps you to understand the difference. Remember that fat embolism is the fat globules, where the obstruction on the blood clot embolism, of course, is a blood clot. The fat embolism comes 95% from fractures of the long bones within 48 hours. Usually it's 12 to 48 hours. Where the blood clot embolism, 85% comes from a deep vein thrombosis that is formed in the leg or pelvis. It can happen at any point, not necessarily due to the injury, but it can be surrounding factors that could have already been present. The assessment findings, the only difference between the two, again, is the petechiae. And remember, the fat emboli, you have the petechiae in the chest and axillary area, in 50 to 60% of them. In retinal hemorrhage, you can actually see the fatty emboli sometimes in the eye. Okay, this is a picture one of the students had from last semester in PEDS that I really liked, and I had asked at that time if I could save it. It's just great. It combines everything that we've talked about. Of course, it's the 6 P's, because they don't have the poikiothermia or the temperature thing in here. As the 6th talks about your nursing interventions, we're going to go over splinting and some traction things, your cast care infections, fracture reduction, all these complications you can have, the acute coronary syndrome, different things that cause pathological fractures. I just thought it was a really good compiling of everything. Okay, so management of fractures. The biggest is doing your assessment. Always remember to do your neurovascular checks, your education, different kind of castings. This is the fiberglass, which of course is much better than the plaster as far as being able to dry rapidly instead of in like 48 hours. This is being applied here. And again, you do neurovascular checks after you wrap it up and place the cast on. This is just a picture talking about the different types of fracture stabilization. You can have a splint. Sometimes they do an internal fixation in surgery. This is an external fixation here, which we've covered in the past. External fixation here, it says dirty wounds or extensive soft tissue injury. If they can't take them to surgery, a lot of times they will have to do the external. They may later do internal. Sometimes just being able to do a closed reduction where they pull the bone in place without having to go surgically inside, and then they splint or cast it and allow it to heal. I thought this picture was cute. Are you sure this is the correct treatment for your broken leg? Keep in mind, of course, an appropriate splint. If this is a broken leg, you would be using crutches. If it's an arm, you're going to do a sling. Just keeping in mind the appropriate management, elevation, neurovascular checks, education to the family, to the patient themselves, moving the fingers, proper range of motion. Hot spots on the cast is a sign of infection underneath. Not to put anything underneath the cast. You should remember all the essentials of cast care without me covering it again at this point. And this is a picture that covers multiple different types of traction. Again, we've covered traction in the past. If it's a skeletal traction, remembering to do your pin care, keeping everything loose. I've got a couple of slides that really are helpful in helping you remember everything. You have in your text, page 1060 and 1061, table 51.1, types of casts used for musculoskeletal trauma. And then table 51.2, types of traction used. They can have it in the upper extremity, lower extremity, spinal column, pelvic traction. And I just gave you the picture of all the different kinds here. This is a really good picture on traction showing the balance suspension with a skeletal traction. It's hard to see that there's actually some pins in there. You notice the foot plate for prevention of foot drop. This is for skeletal traction looks like for the it's going into the tibia here. I like this slide. There's this and the next one are really good slides on mnemonics for care of the client in traction using fracture, firm mattress, and foot drop, a board for them to push their foot against so they don't develop foot drop. Range of motion for unaffected extremity, keeping it aligned, watching for complications which are addressed more in the other, like here the respiratory, urinary. You're of course evaluating GI. Your trapeze, they'll go back, you see your trapeze over here, keeping this aligned here where your shoulder, your hip, your foot. Checking for urinary tension, respiratory complications such as pneumonia, elevate, circulatory impairments, doing your neurovascular checks. Here's another mnemonic using the word traction, looking for infection with your temperature, keeping your ropes hanging freely. A for alignment, C for circulation checks. It should be 6 P's, not 5. T, type and location of the fracture, increasing your fluid intake. O for overhead, trapeze, and for no weights on bed or floor. I just thought those were very helpful mnemonics and things to remember. And always keeping in mind your neurovascular checks and complications of bowel obstruction, constipation, urinary tension, pneumonia, blood clot formation, fat embolized symptoms, compartment syndrome, all those multiple things. And if they have ORIF that you're looking for, not an ORIF, not an open reduction. If they have an external fixation, you're going to do your pin sites, your pin care. Internal fixation, and you're closed up and you're doing incisional care. Okay. So we're going to go into hip fracture a little bit. Text doesn't talk too much. It just briefly covers upper extremity fractures, immobilization, elevation of the applying ice if needed, managing pain, removing jewelry on the affected hand or wrist. These are all very logical. You might want to just look over these, make sure you understand them. Lower extremity fractures, and it addresses fractures of the hip. You have a figure 51.8 on page 1067, just talks about the multiple places where the fracture can take place in the femur or intercapsular fractures, multiple places. This has a prosthesis showing figure 5110 for actual hip replacement prosthesis. There are a lot of action alerts on page 1068. The first one, patients who have an O or F are at risk for hip dislocation or subluxation. Be sure to prevent hip adduction. Remember, adding is coming together. You don't want the hips to come together. You will use an abduction pillow to keep the hips apart, because you don't want them to add, you want them to go out, abduct. And you don't want them to rotate. You want to keep the operative leg in proper alignment. Regular pillows or abducting devices can be used for patients who are confused or restless. If straps are used to hold in place, check the skin for signs of pressure before neurovascular assessments. The next alert just says be sure that the patient's heels are up off the bed, because you don't want pressure on them, on bony prominences, keeping them moving, copying deep breathing, repositioning. Okay, so this is a good picture for a hip fracture. Your bucks traction, which is often used pre-operatively to help with the pain and stabilize the leg. Risk factors are age, female, osteoporosis, anything that causes a decrease in estrogen level. People that are more at risk for falls, multiple reasons here. Your priority is hydration, respiratory, sports, circulatory checks, pain control. Mention of immobility complications, which you know at this point, your DVT, your GI problems, your urinary retention, your pneumonia. This is just some pictures. Like I said, your text has a picture with multiple fractures. This is just a picture of one with a hip fracture. You see right here, the whole head is fractured, intertrochanteric fracture. This is another good, busy picture, but a good one for you to look over. All the multiple things, your neurovascular checks, your post-op care. If you noticed, these are complications. The fat embolism, remember, with the hip and pelvis are very key places to throw a fat embolism, or even just a thrombosis that becomes an emboli. You want to check, there's a risk for avascular necrosis. You go back, if you see here with the fracture, the bones are very vascular. And even with the hip replacement, sometimes if there's or in here, the vascular is cut off and they can get an avascular without blood flow necrosis of that place. So the bucks traction, which I mentioned, complications of immobility, internal fixation, pins, screws, plates, prosthesis, depending on what the fracture is and what they need to do. Nursing care, maintaining abduction, changing position every couple hours, cough, deep breathe. These are all things you should know. Just look over this. Pain management, of course, no weight bearing, keeping them aligned. Here's another picture with the hip for post-op care. There's your abduction of the pillow, and your neurovascular checks, checking for clots, urinary retention. Okay, so that is actually the end of part 1. I said this is not a bad chapter, and if you want to continue on part 2, there's only one more section for chapter 51, and this chapter will be done. Thank you.